Hello, my name's Ian McCall, and this is another of the consultations in dermatology from the Australian Institute of Dermatology. Today we're going to talk about the golden crusts, impetigo. Well, the first thing to say is that not every case of impetigo is going to have these golden crusts, which is a shame because that's how we've entitled it. Impetigo presents with flaccid blisters and crusts. Now by that I mean the blister is very superficial, so it tends to burst easily, and it may dry and form a crust. When that crust's formed, it's often golden yellow in color. The organisms that are involved in this are staphylococci and streptococci. And some people feel that the strep variety is more likely to give you the golden crust than the staph variety. I don't see as much strep now as I used to. It tends to virtually always be staphylococci. And if there are strep, usually there's staph there as well. In the true bullous impetigo, when a very definite blister is formed, then there's usually a particular toxin-producing type 71, that does this. Treatment, we'll outline that below, but this is the last thing. This is a highly infectious disorder. It's very easy for this to spread from one person to another. And this is why it goes by its colloquial name of school sores. When it starts in a school, it's very easily spread by one child to another just by contact. And the contact can be via the person or via inanimate objects that they've touched. So it's important to isolate someone who has a staph impetigo, at least until they're on good either topical or oral antibiotics. What we might do is do this presentation as a PowerPoint. So let's have a look at this. Okay, the first series of images, this is the inner aspect of a chap's upper arm. He had atopic dermatitis, and he developed an infection superimposed on this, because often staphylococcal infection is superimposed on a pre-existing skin condition. Now here you can see the remains of the very flaccid blisters. They're just around the outside. You can see the slightly golden crusts here. You can see how superficial this is, because any toxin that's produced in this condition is acting just underneath the stratum corneum, so it's a very thin blister. Here is another case, and this is the sort of blister that you're going to get. And you'll sometimes see a little fluid level in that blister as well. These are pus cells within the blister. It doesn't last terribly long, and it will often burst and form a dry crust, often an annular sort of lesion. It may look even like a ringworm. Here's a good example of just the ordinary type of impetigo, where you've almost got central clearing here, and you've got your crust and an erosion around the periphery. A bit more crusting, in fact, here. A little bit of involvement here as well. Very often they have an infection in the nose itself. You can see a bit of that here, and the organism seems to spread from this reservoir to the other areas in the face. Here's another boy who was being treated with Roaccutane for acne, but he started to get staphylococcal infection. Here you can see the small pustules in this case, and again the crusts where the lesions tending to, where the blisters have been and they've dried up. Here's a case certainly of marked golden crusts, and it used to be believed that streptococci were much more likely to do this. They seldom, the streptococcal variant seldom forms actual blisters. It tends to go straight into this sort of crusting stage. And I think we have a better close-up here. You can see what we mean by adherent golden crusts. There's really no signs of any blister in this variety, but there isn't an awful lot of erythema around about either, and that may confuse you a bit. You're used to staphylococci giving rise to a sort of cellulitic picture with a lot of heat and local pain in the surrounding skin, but that may not be the case. This was another case again to show this tendency
to form blisters with a little fluid level. Here it's not quite in focus, it's eroded. And this is where the blister's forming. Note, it's substratum corneum. It's very high up there. You've got most of your epidermis in the base of this. This is a mixture of leukocytes, pus cells in there. And this is the stratum corneum, as you can see it here. It's all that's holding the top wall of that blister, so it bursts very easily. Now, other things can look like this. Here you've got grouped pustules on the face. They may have been clear vesicles at first, and then they become pustules. Similarly here, you can see very early ones starting here. But these have burst a bit, and they're appearing to form a bit of a crust. And you may think this is staphylococcal infection, but it isn't. It's herpes. It's herpes simplex. So this is one of the differentials of an impetiginous eruption around the mouth or around the nose. And it indicates the importance of, in fact, doing swabs when you see these cases. And not only do you swab for bacteria, you send a viral swab as well. You'll never do wrong if you, in fact, do this. It will avoid you making mistakes sometimes. Here's another example of herpes, in fact, around the mouth here. And again, note the difference in the blisters. See how these are small grouped vesicles rather than that flaccid soft wall blister that you had with a bullous impetigo. Mind you, that's not to say you couldn't get a bit of secondary staphylococcal infection on this eroded skin. So again, this is why swabbing for both herpes virus and staph is important in this. And here's another case where the background rash that you're seeing here is someone with quite marked atopic dermatitis. But suddenly they developed a painful eruption in this area here. There have been small erosions now. You've got some crusting here. You might think that that's perhaps a staphylococcal infection, but it isn't. It's herpes virus superimposed on underlying atopic dermatitis. So again, the virtue of when you do your swab, not only do one for bacteria, do one for viruses. Some staphylococci have a toxin. I think we mentioned the type 71 staph, and they produce a lot of toxin, and this toxin can spread via the bloodstream to various parts of the skin, and it can give rise to what's called the staph scalded skin syndrome. You can see how red this skin is and how painful it is. Often you won't in fact see true blisters, but the skin will just sort of peel, and a very superficial peeling at that. You see this more in children. You can see it in the elderly as well, especially if people are a bit immunosuppressed. Then they're more susceptible to get this problem. But the damage is all superficial. This isn't going to scar, and it will respond to intravenous dicloxacillin. Here's another example in an elderly patient. There may even have been a dermatitic element here too, but you can see how the skin has peeled in a very superficial way. There's another condition, though, that can look like an impetigo, but it's seen in older people. That's not to say impetigo can't occur in older people, but if you've got someone over the age of 60 and they seem to be presenting with an impetigo, look at them carefully. They may have the condition called Pemphigus foliaceus. Now, Pemphigus is one of the immunobullous diseases. You produce antibodies that attack the proteins that hold the keratinocytes together, and these proteins are called desmoglians, and they're part of the desmosomes that are the molecules that hold the cells together in the epidermis and give it its structural integrity. But in Pemphigus foliaceus, you have an antibody produced to one of these proteins, and it attacks it. So the cells of the epidermis fall apart. They just give way and fall apart, and they may form little blisters. But more likely in this condition, they'll actually form just crusted erosions. Let's have a closer look. This is the same person's back, and you can see the little erosions here. You can see some of there's some erosions there. You can see some crusting elsewhere. So if you see an elderly person coming in and you think, oh, they got some form of impetigo, make sure that you consider Pemphigus foliaceus as a differential. Here, you need to do a skin biopsy. You need to take a little ellipse of skin here and send it for both histology and immunofluorescence. There's a special culture medium for a special transport medium for the immunofluorescence. Here's another example of this condition. This also is Pemphigus foliaceus, but look at it. It looks very similar to the lesions that you'd get with impetigo, with sort of a pant clearing in the middle and the blistering and the crusting, I should say, on the outside. You might also look at that and wonder if it's ringworm, if it's a tinea infection, or perhaps an annular erythema. But if you look out here at the periphery, look at these more inflammatory edge to this, look at the peeling here. It's a toughie. I would have swabbed it, I would have scraped it, and if it was an elderly person, I would do a biopsy. Because the area in Pemphigus foliaceus, the damage is so high up in the epidermis, just around the level of the stratum granulosum, that you just don't get much in the way of blisters. It doesn't stay intact. It forms these sort of crust or erosions, sometimes in this annular pattern. Not a common condition, but an interesting one, though, to remember. This was a patient I had who had Pemphigus foliaceus. And note the erosions. There's been a little blister here, but it's burst, and you've just got the slight side wall of it here. Here are some areas that have partially healed. This is a tough diagnosis to make, and this was the area where I said there had been a small blister, and it had gone like this. You'd taken the ellipse across that and send it for immunofluorescence and for ordinary H&E. Here are some cases just to end up here, and we can talk a little bit about treatment as we go along. This was a 3-year-old girl brought in by her mother with an itchy, rapidly spreading rash in the left axilla. She attends daycare, which involves playing with other children in sandpits. Mum thought she might have been bitten by some insect or ants, and she had the crusted lesions, superficial skin loss, and mother did volunteer seeing blisters filled with cloudy fluid. So this is your typical impetigo. There's just the outside edge of where there's perhaps been a blister. You can see it perhaps in better focus here, the different types of lesions that you're going to see. So what would you do here? You'd do a swab. If you're going to do it for bacteria, you might as well do it for viruses. You'd certainly examine the child elsewhere, look and see if there's a little focus of infection in the nose or some other area. If it's only localized like this, you may get away with treating it with just topical Bactroban cream applied twice daily. Get rid of any crusts that are there. First of all. If it's quite an extensive case, then consider the use of some flucloxacillin syrup. Make sure that mother washes or keeps this child's towel separate. Make sure she hot washes it, because staphylococci can survive cold washing. And make sure that she's kept separate from the other children, and that the clothes are all hot washed too, to avoid spread to other members of the family. Here's another case from overseas, and it shows a much more bullous and blistering variety. Again, the infection centered around the nose with the crusts in this area, and a blister here. Look at the fluid level of pus just in the base of this little blister. It's amazing it still stayed intact, considering how superficial it is. These ones that aren't quite in focus show you the crusting, the annular sort of lesions that you're seeing elsewhere. Again, the same basic principles. This isn't the picture that you'd obviously see in herpes simplex. It doesn't form. It's grouped little vesicles. It's not going to form a biggish one like this. So you can be virtually certain that this is a staphylococcal infection. And this particular patient was treated with oral fluclox and topical Bactroban, and to both nostrils, because the nostrils can be a reservoir for this infection. And as Patricia said there, trace and treat the source of the infection. Is there someone else at home who's in fact the source for someone getting reinfected? Separate towels and linen. And the last case was an interesting one, a 7-year-old girl who presented with a rash coming out initially in this area here. just in this area, a few days of sores over her right upper lid and brow, and presented with these crusty lesions, golden red base. Systemically well, no other lesions elsewhere, no clear history of vesicles. She'd had chickenpox previously, no history of cold sores. Had her eye examined just to see if there was any involvement on the surface of the eye. A fluorescein stain would have been done, but it was normal. Her other GP had started on famciclovir. Now, this is an agent that's used if you think this is herpes or herpes zoster. And that was because of it seemed to have a unilateral distribution, not crossing the midline in this area. And apparently further down there was a bit of redness at the tip of the nose. Now, this is also a feature that you may see in ophthalmic herpes if the nasociliary nerve's involved. You can't really see it much there. But that wasn't the case with this girl. She did have swabs sent for both staph and for herpes, and this was another lesion that came up. Now, again, that's not the sort of Dell-shaped vesicle that you'd expect in herpes. And in point of fact, this was all just a staphylococcal infection. There was no herpetic element there. This wasn't zoster. And she was given some Bactroban, and one could also have given her some flucloxacillin if necessary. Again, soak to get rid of all of these crusts here, then apply your Bactroban twice daily. So to summarize treatment for impetigo, or suspected impetigo: swab for bacteria and herpes virus, soak off the crusts, mupirocin cream, Bactroban cream twice daily, very effective in this condition. If you're needing antibiotics, consider flucloxacillin, consider erythromycin, but make sure you've done a swab so that you can see what the sensitivity patterns are, because sometimes you're going to get an organism that's resistant to flucloxacillin, a methicillin-resistant staphylococcus. If, say, you had cultured and you had got a streptococcus, and it was a really extensive case, then in those sort of cases, you've just got to watch for post-streptococcal glomerulonephritis. So you've got to just check the urine, make sure there's no blood in it, and just check the blood pressure of these children as well. I mean, we don't see it much, post-streptococcal glomerulonephritis nowadays, but in some Aboriginal communities in Australia, where there's a lot of scabies as the initial infection with rubbing and scratching, that breaks the skin, the strep gets in, they get a strep type impetigo, and they can get streptococcal damage both to the heart valves and to the kidney. And it's a common cause of glomerulonephritis in these sorts of populations. An antiseptic body wash is also useful. Physohex, chlorhexidine, one of those. It helps to deal with it. Hot wash the towels, keep the person's towels separate, and hot wash the clothing that's in contact with the skin. And if you get someone who's getting repeated infections, then check out the other members of the family. There may be someone who's in fact a carrier of staphylococcus. You need to do swabs from the nose of all other family members and just see if someone else is in fact a carrier. And in someone who is getting repeated infections, treat them anyway with Bactroban mucosal ointment for the nostrils twice daily for 10 days to deal with any persistent nasal carriage that that individual may have. So it's an interesting condition, the condition of the golden crusts of impetigo. There's a variety of things to consider. I think the important things are to take swabs and also take viral swabs. Consider if you get excess golden crusts like this that it may be the streptococcal variant, and if there's streptococci found, then check the kidneys for glomerulonephritis. Make sure you're considering herpes as a differential of impetigo. Consider the staph scalded skin, and consider Pemphigus foliaceus, as one of your differentials in this condition. I hope you've enjoyed this presentation. Thank you very much.